Hi, my name's Rob, and this is a short-ish video just demonstrating some of the research I'm doing as part of my clinical PhD. So just a quick introduction and a bit of context. I usually work as a cardiology doctor in an NHS trust called the Southern Health and Social Care Trust, it's a bit of a mouthful, which is in Northern Ireland. But at the moment I'm taking a sabbatical from that work to do a PhD based largely in artificial intelligence, but also computerized simulation for healthcare. That's at the University of Ulster. It sounds very dry, I know, but hopefully I'm about to convince you that it's more interesting than it might first appear. Just to get a couple of mentions in, the research is funded by the European Union via the Interreg programme, and we have a lot of support from our local Craigavon Cardiac Care Association charity. The reason I'm making the video today is that I'm away at the Rework Deep Learning in Healthcare conference in London, and they've been kind enough to give me an exhibition space. So I've put together this demo for that purpose, and I have the run of a flat without my kids screaming at me and running riot, so it seemed like a good opportunity to do this. I'll explain all the technicalities of the demo at the end, because I know a lot of people won't be interested in that. And unfortunately, because I've only got my laptop with me, I can't record the screen as the demo runs because it needs too much computing power. So I've had to take this video on my mobile phone, and you'll notice the resolution is pretty poor. Also, the performance of a couple of bits of the demo when actually it's putting some deep learning into use is a bit slow. You'll have to take my word for it that on a proper computer, it runs quicker than that. So without further ado, I'll run the demo. It's about 6 minutes long, and then I'll spend another 4 or 5 minutes explaining exactly what's happening and why this might be important for the future of AI in healthcare research. Okay, so just before we start the scenario, what I'm going to do is I'm going to generate randomly 2 rhythms. We're only going to run through 2 cycles of CPR, by the way, just to prove that the resuscitation bot, Bob here, can't possibly anticipate in advance how the scenario is going to run out. So what I'm going to do is I want to generate a random shockable rhythm followed by a non-shockable rhythm, just to show you that Bob can switch between the different sides of the CPR algorithm. So we'll choose VF and Mobitz 2 as 2 appropriate rhythms for that reason. And I'll let Bob do the rest of the talking.
Hello everyone, my name is Bob. We are about to undertake a simulated cardiac arrest scenario. Our virtual patient is called John. He had an elective hip replacement 2 days ago and has been recovering on the orthopedic ward. This morning he was found unresponsive by the nursing staff and an arrest call has been put out. Managing cardiac arrests is something with which many human practitioners struggle. Clinical decisions must be made quickly and under intense pressure, where simple errors in judgment can make the difference between life and death. During this demonstration, I will attempt to show that an AI system such as myself can successfully lead a team of practitioners through a cardiac arrest scenario. To do this, I will be using deep learning to derive pertinent clinical information from my environment and rule-based AI to make guideline-based clinical decisions. Alex, can we start by confirming cardiac arrest, please? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. There's no pulse and no respiratory effort. Thank you, Alex. Charlie, please start chest compressions. Continue without interruption at 100 beats per minute until I tell you otherwise. Alex, please switch on the defibrillator and attach the pads. I am now going to locate the defibrillator by processing my camera feed through a convolutional neural network. I will then zoom in on the defibrillator and use a separate CNN to analyze the rhythm being displayed on the screen. I think this rhythm is ventricular fibrillation. That is a shockable rhythm. Charlie, continue chest compressions until I say otherwise. Alex, Please make sure any oxygen is away from the patient and charge the defibrillator. Charlie, please stop compressions and stand clear of the patient. Alex, when you assure everyone is clear, please deliver the shock. Please resume CPR at a ratio of 30 compressions to 2 breaths. I will now ask the team to gain IV access and administer a bolus of 500 milliliters of normal saline. We are on the shockable side of the algorithm, and that was the first shock, so I will not give adrenaline or amiodarone at this point. During a cycle of CPR, I will be considering the reversible causes of cardiac arrest. These are hypotension, which we are addressing with intravenous fluid; hypoxia, which we are addressing with oxygen administration; hypothermia, which is unlikely on a hospital ward; electrolyte disturbances, which we will exclude with urgent blood tests; cardiac tamponade, which seems unlikely in this case but which we could exclude with a focused echocardiogram during the next rhythm check; tension pneumothorax, which we have excluded clinically because the patient is easy to ventilate and has symmetrical chest wall movement; toxins, which we will exclude by reviewing the medication administration record; and finally, thrombosis. This is the most likely cause of arrest in a patient who has recently undergone hip surgery, and thrombolytic therapy is a reasonable option here. However, I am not yet at a stage in development where I am confident to make this decision independently of a human practitioner. For now, we will continue CPR and await the arrival of a senior clinician. On which note, it's about time for the next rhythm check. I think this rhythm is wanky back. That is a non-shockable rhythm. Please resume CPR at a ratio of 30 compressions to 2 breaths. We are now on the non-shockable side of the algorithm, so I will ask the team to give 10 milliliters of 0.01% adrenaline intravenously. We'll end the simulation here. But in practice, we could continue to follow the CPR protocol as long as is necessary. There is ongoing research into the use of deep learning in prognostication, and it may be that in the near future an AI is every bit as capable of making the decision to stop CPR as a human practitioner. Using an AI to make autonomous clinical decisions, rather than simply as a decision aid for human clinicians, is somewhat controversial. However, cardiopulmonary resuscitation plays to many human weaknesses, as it is high pressure, time critical, and opportunities to practice can be few and far between. This, combined with the fact that decisions in CPR are heavily protocol driven, may mean that an AI system outperforms humans in this particular field. The next step in our research is to put this hypothesis to the test, so watch this space.
So hopefully you'll agree that our resusci-bot Bob did a pretty good job of managing that cardiac arrest scenario there. And so the question now might be, what was the point in that? Where are we going with this? And another reasonable question might be, should we be pursuing this kind of research? Because seeing robots manage patients, even in that kind of virtual environment, probably makes some people uneasy. So first of all, what was the point in what Bob was doing? Well, a lot of the deep learning and healthcare applications that are coming out at the moment are single step, what we call supervised learning problems. And I'm not going to bore you with the details of what exactly that means, but we're talking about diagnostic tools like looking at an X-ray and making a diagnosis of lung cancer, or looking at pathology slides and deciding whether a tumor is benign or malignant. Things where the AI has to do one thing and then its involvement in the case is finished. That works very well. What we're going to be looking to do in the future, I think, is we're going to be looking for AIs to get more hands-on with the case and take sequential actions, which is a very different prospect from the point of view of machine learning. Once an AI starts to actually interfere with an environment, you encounter a whole host of problems, because by changing its environment through the actions it takes, it is making the environment different to environments it was trained on, usually, assuming it was trained to imitate human actions, which is often how these things go. And so there's a really interesting problem here of how you overcome that, particularly in the field of healthcare, where you can't deploy a deep learning system until it's more or less perfect. So you can't put it out there like you might take an autonomous driving AI that drives a car. You might put it in a very safe environment and allow it to make early mistakes. And then you iron out those mistakes and you put it in a slightly more challenging environment, and so on and so forth, till it's finally ready to go on an actual road. Healthcare, you can't do that because you've got this zero tolerance environment. We can't have developing AI systems harming patients while they iron out their flaws. So my research is looking at, can we use simulated clinical environments as sort of a stomping ground for AIs as they learn their stuff, as they iron out their flaws, and as they get ready for clinical development. Which sort of leads on to the second question of, should we be doing this? Should we have AIs actually making decisions regarding patient care? I think we should. I think we're a long way off that. My research, I have no ambitions of actually deploying an AI in a real world clinical scenario with an actual human patient. So to a certain extent, the ethics are maybe not quite my problem. That's not to say I'm different. That's just to say I'm not qualified maybe to make sweeping judgments here. But I think we should be aiming for that, because scary though it may seem, particularly perhaps to doctors and nurses and clinicians whose jobs seemingly are at risk here, all computer technology has ever really done for us in healthcare and in other fields is allow us to do something called cognitive offloading, which is where we take tasks that we once had to perform, hand them off to computers, and free ourselves up for more uniquely human tasks. And for the foreseeable future, that continues to be the role that AI is going to play. I know people have dreams about autonomous androids that basically have human level intelligence, but that's a way off. What I think AI could be doing in the not too distant future is taking away from us some of the data processing activity that we as clinicians do. So in cardiology, I spend a lot of my time accumulating data, processing it to form a diagnosis and treatment plan, and then implementing the patient's management, starting new drugs or undertaking procedures. That's something that computers should be able to do very, very well. In fact, better than us, because they have the capacity to process vast amounts of data quicker than us humans, and without human flaws such as being subject to stress, fatigue, bias based on past experience. There is something called algorithm bias, which is very, very important, but I'm not going to go into that. If I imagine that the kind of AI you just saw, so Bob, was actually ready for deployment in 10 years' time when I'm still, in the middle of my career, that doesn't scare me that much, because if I could hand off tasks like, managing a patient who's in cardiac arrest by following the CPR protocol to Bob, actually, I think that would be a good thing, because not only would Bob probably do a better job than me, because he will follow the CPR protocol perfectly every time and he will forget nothing on that protocol. That then frees me up for tasks that Bob can't perform. So it'll give me time to speak to patients and their families, to communicate in a human way, to make higher level decisions. So not just if I have a patient who's 88 years old and has heart failure and a bit of dementia, not just to work out what the optimal treatment plan is for that patient, but perhaps to sit down with the patient and their family and say, listen, what do you want to do here? Should we be giving you the optimal treatment, the optimal life-prolonging treatment for heart failure? Or should we be focusing on something else? Does the diuretic we give you make you run to the toilet every 2 minutes and make you miserable? Do we understand that you might have less than a year left to live, and what are your priorities? So those kind of things that fall by the wayside a bit now, I think we could be freeing ourselves up for by using AI. In terms of the technicalities, I will sort of whip through this, because I know very few people are going to actually be involved enough in computer science to understand what I'm about to say. But what did Bob just do? Well, Bob has access only to a video feed of his virtual environment. The reason being, I want all of this to be scalable to a real-world environment. Even if I'm not actually going to be the one doing the scaling, what I want to do is prove concepts that are transferable to real-world clinical practice. So all Bob has access to is a video feed from a virtual camera that's mounted on his head. He has algorithms programmed in, so when he's making decisions about, the shockable versus not shockable side of the algorithm and what actions he should take, so giving a shock or giving saline or giving adrenaline, that's all hard-coded in traditional computer programming. But what's new and unique about what Bob's doing is he's able to process his camera feed to make sense of his environment. So what you saw him doing, this was a bit laggy in the video, but what you saw him doing was he looks around and he finds a defibrillator, and you see a little red cross appear on where he thinks a defibrillator is, having processed his video feed through something called a convolutional neural network. And then he zooms in, he finds a defibrillator again, and he incrementally gets closer and closer till he's got an adequate zoom on the defibrillator to read the trace on the screen. He then reads a trace on the screen and makes a diagnosis of the rhythm, also through a convolutional neural network. And interestingly, this is the network he's using is actually something called VGG16, which was developed at the University of Oxford. And this is a network that's been trained on millions and millions of real-world photographs. And you can download this for free, this pre-trained network, and then you can retrain certain layers. So what this convolutional neural network does is it's a network with lots and lots of layers that it processes an image through, and it's incrementally taking more abstract or deriving more abstract data as each layer goes by. So in the first layer, it might be just simply finding straight lines and curves. In the next layer, it's putting them together to find shapes. In the 5 layers in, it might be able to identify the shape of a human body versus the shape of a vehicle, and so on and so forth. And so what I've done is I've taken that network and I've retrained the last 4 layers, so the highest level of abstraction, so that instead of looking at real-world photos, it's looking at ECGs. And for some reason, that just worked. There was a lot of playing around to work out what the optimal setup was. And that just worked, and then I added in a couple more what we call fully connected layers. And it's got a really good hit rate on this virtual defibrillator, which has simulated ECG traces. What the next step is to transfer that learning back into the real world by getting real world ECG traces and then retraining the last couple of layers of the network so that it can take what it's learned in a virtual environment and apply it to a real world environment. And hopefully the same will be true of the camera feed. So when he finds a defibrillator, he can only at the moment find a defibrillator within this virtual environment. But it shouldn't take too many training images of a real world environment and real world defibrillators to just transfer that learning across. It's all very interesting, I think. In the future, what I want to do is I want to get Bob into much more complex simulated clinical environments and use something called deep reinforcement learning to basically mimic what human experts do. And what we tend to do, we get raw sensory information from our environment, we process that in the usual way to derive abstractions from it. So I might look at a room and I'll see a patient, defibrillator, cardiac monitor, I'll read the trace on the cardiac monitor, not just me, any clinician. And then over time, as you accumulate experience and expertise, what experts tend to do is they will make subconscious decisions very, very quickly. And then they will put them through sort of a rule-based sanity check. So they will consciously think about the decision that they've subconsciously made, check it's okay, and then put it into action. Most of us have experienced that through driving. We don't think about driving, we just do it subconsciously. But if driving gets challenging, if you find yourself, in bad weather or someone crashes in front of you and you have to take emergency action, that tends to be how we work. We make subconscious decisions, we filter them quickly through a conscious thought process, and then we take action. And we're at a stage in the development of AI research where you can do that with an AI. And I think it'd be really interesting to see, does that result in a very effective clinical decision-making AI? And then, if there's time during the scope of the PhD, it'd be really nice to evaluate an AI that's using that kind of setup against your average human practitioner within a simulated medical emergency, not just a cardiac arrest, but a patient who's acutely unwell with a range of different problems. I think that's about it. It wasn't quite as short as I thought it was going to be the video, and thanks for watching. And if you want to get in contact, my email address was earlier in the video. It's brisk-r@ulster.ac.uk.